was saying before that it's very interesting as a physician, I speak fairly often, that very often you speak to doctors and nurses and pharmacists and you can get kind of technical, and some of them really demand it. Some of them argue with you if they don't agree with your interpretation of the science that sometimes they've published, which is fine. But I knew today was going to be different. Today was going to be talking to people, a lot of whom have had melanoma, or their families had melanoma, or they're just generally concerned with it. And I wanted to create a different kind of talk that helped all of you understand what we think about, the data that we see, and how we approach the problem without getting too technical about what it all means and what's the genetics and how the clinical trials are designed and things like that. Now, before I go any further, I want to acknowledge one more person. That's Lydia Nadeau. Lydia's in the very back of the room. Lydia is my counterpart with the oncology service line at Atlantic Health, and between the two of us, it's our responsibility to make sure that all the cancer programs within Atlantic Health, both in Morristown and Overlook and Chilton and Newton and now Hackettstown as of April 1, that all the cancer programs are providing the best benefits to the community. So thanks for coming out this morning, Lydia. So today I want to talk about advances in treatment, really focusing on the non-surgical aspects of care, things that are going on in the world and the way some of you may have been treated. And but again, I wanted to talk about a little bit where we've been, but then really where we are and where we're going in the future, and really hopefully give you guys some tools to be able to think about, what does that mean? How is that different from what I've received or what my family received, and how is it changing in the future? So this is an interesting slide that I found, and it's cancer deaths, all cancers, and then just melanoma deaths. It only went up to about 2012, so it really predates all the great medicines that have been approved, which, by the way, were approved starting in 2011. So the first melanoma drug that was ever approved was DTIC, and that was, I think, in the 70s. It was based on really old data. And then interferon was approved in 1995, and interleukin-2 was approved in 1998, and there was nothing until 2011. So this curve, this graph here, so if you look at the dotted lines, those are all cancer deaths. And you know what? As a cancer community, as a doctor community, we did pretty well, because you can see it was rising in the 90s, and then as it goes into the 2000s, for all cancers, fewer people are dying of cancer. Then we have the melanoma curves. The incidence of death for melanoma in Australia is way higher. You know, I was a history minor. The history of Australia is that England got rid of its criminals on ships and shipped them to Queensland, Australia, which is Sydney, which is beautiful, right? And it's got these great beaches and the barrier reef, and people go diving and everything. But they took a bunch of Irish criminals with red hair and blue eyes, and they stuck them at the equator. That's a recipe for skin cancer disaster. That's why Sydney, Australia, Queensland, Australia, has the highest incidence of melanoma in the world still. That's why the melanoma death rate per 100,000 over the right-hand column is way higher in Australia than it is in the United States. Parenthetically, New Jersey always has a higher rate of melanoma than anywhere else in the country, except for Florida. Why? Who goes down the shore in the summer? By the way, if you go everywhere else in the country, people are like, what are the beaches like in New Jersey? No, not beaches. It's the shore. People go down the shore. When we moved here, our kids they're like, what's the shore? What are they talking about? So we had a lot of room for improvement. This graph would be really interesting to see in 5 years. I think we're making a difference now. The textbook answer for survival when melanoma spreads to other parts of your body beyond the lymph nodes has always been 6 to 9 months on average. Some of you in this room were told that by me a long time ago. And since you're in the room, I was wrong, and I'm glad. It's always good to be wrong about things like that. These are some old studies. These are publications from 2006. And I'll give you a little hint of what is to come. These are survival curves. Survival curves tell you the chance of something happening over time, typically living. So everyone starts at 100% because at the beginning of the study, everyone's alive. And then over time, which is the bottom axis, and these are in years, unfortunately people with cancer, especially when there's no good drugs, and these are old chemotherapies. I say old. Sometimes you can go to Sloan Kettering and still get these chemotherapies when everything else has run out. And same thing true of all places. But these were the sorts of things that we used to argue about. Is this drug alone, DTIC, which was approved in the 70s, better than cisplatin plus vinblastine or vindestine plus DTIC, CVD? We used to sit at meetings and argue about this in the pool, in the sun. I have very vivid memories of being in a melanoma meeting in Hilton Head, South Carolina, and everyone sitting around poolside arguing about what chemotherapy was better. It was really funny and ironic. But look at this. In a year, half the people have died. And that was true, didn't matter which chemotherapy you got. All those curves superimposed. That's where we were for decades with melanoma. No matter how many times the oncologists combined different drugs, they got the same result. 50% death rate within a year. 50% death rate within a year. But you know, you got to know what you're looking at. You got to know how to interpret the data. Because, and by the way, there are great graphics online. The companies, I think the pharmaceutical companies pay for these. Is that cool? We are drawing a bead on cancer. That's the cancer cell, and there we are. We're targeting it. So I talked about survival curves. You can actually plot anything on a survival curve as long as it changes over time. And this is the actual formula that two statisticians, Kaplan and Meyer, published. I thought it was in the 1920s, but I may have been off by a couple decades on that. That's okay, it doesn't matter. This is used to predict the risk of a stock going down or of a company going bankrupt in a certain industry. It's also used to predict the odds that you will be alive or the odds that you will not have cancer or have cancer over time. This is not actual survival. This is the mathematical model that predicts the risk of you dying or risk of you having recurrent disease based on the number of people that are still this far out in months versus how many people have had an event. So this is all about how many events occur over time, and the denominator is how many people might have an event. So that's a survival curve. The coolest thing about drugs that work is that you have to make up new ways of evaluating them. This is called a waterfall plot. And they get to come up with really cool names for them too. This is a waterfall plot, as it turns out, for vemurafenib, which was what it was called then. It's now called Zelboraf. And I'll talk about it more in the future. But a waterfall plot helps us understand, not over time, but in a big picture, how many people got treated and what the results were. So at baseline, everyone has a certain amount of cancer in their body, and that's 0% change right here. And once they get treated, they're evaluated by scans and by physical examination, and either the cancer shrinks, which is the line going down, or the cancer grows, which is the line going up. You look at that picture. Once you know that, and your immediate thought is, most people did well, right? Most people, the tumor shrunk. Some of them, the tumor went away completely. That's 100%. We call that a complete response. Some of them, it shrunk more than 25%. Imagine a line right there. And that's called a partial response. But even if you didn't get a complete or a partial response, some people, the tumor still shrunk. So each one of these lines represents one person, and you can change the color based on disease stage or where the melanoma is, if it's on the extremity or the head and neck or the trunk. You can change the color, and you get an immediate great representation of how well did a group of people do. They did pretty well. You'll see some other curves where they didn't do as well. And how what's the magnitude? But again, even if they don't hit that threshold, even if everything doesn't shrink, only a small percentage of people did the cancer actually grow. So that's a very impressive waterfall plot. And you know what? When you give chemotherapy and 5 out of 100 people, the tumors shrink a little bit, waterfall plots aren't very interesting. Because things happen over time. And sometimes you give a chemotherapy drug or another drug and everything shrinks right away and everyone's excited. And sometimes it doesn't shrink right away. Sometimes it does weird things like grow initially. And now we have things called spider plots. I can assure you that I never heard of a spider plot until 2012 or 2013. And that's because we didn't have drugs that made any difference, because what happened when you got treated with cancer? Either everything grew or everything shrunk. Now we have a mixture. So this is a spider plot. Everything starts out at 0 because nothing has changed yet. And then over time, and this is weeks since treatment gets started, and each one of these actually represents a group of patients, and this is nivolumab or Devo. This is the phase 1, the earliest phase data that made the cover of every newspaper in the United States. In different sorts of cancers, lung cancer, melanoma, kidney cancer. This is the group, these are several patients grouped together, and you can actually selected patients. You can see that some patients, things just shrunk right away, down to 100%. And some patients, it shrunk a little bit, but it didn't do anything. You know what? If you can turn a cancer into a chronic disease, even if it doesn't go away completely, I think a lot of us would take that. So there you have some people over here. That's called the tail of the curve, where things went away a little bit, but they didn't grow. They just kind of stayed away. And then you had some really fascinating people, which is hard to understand completely and hard to deal with for everybody in the room. Things grew, and then they shrunk. This is the interesting part about some of the immune therapies. Our immune system doesn't respond like we would like it to all the time. The word is the kinetics of response are a little murky. Sometimes it goes up, sometimes it goes down, sometimes it changes quickly, sometimes it doesn't. So this is called a spider plot. Spider plots are what happens over time, how do things change over time. Now, anyone have children who swim on a swim team? We didn't, because my wife, she said, the last thing I want to do is spend my day in a swimming pool with all that chlorine. Not doing it. Anyway, I'm sure if they liked it, she would have. This is called a swimmer's plot. A swimmer's plot gives you an idea of how long the response lasts. How long does the effect last? And again, before we had medicines that worked, this wouldn't have been interesting, it wouldn't have been fun to look at. Now it's fun, because now you have patients, again, this is the initial study with vemurafenib or zelboraf, and you can see each one of these lines represents a patient. And it's a patient who responded to treatment and things started to shrink. The diamonds here are when they started to respond. Now, why did they all start to respond at the same time? It turns out that's a really simple answer. The way the protocol was set up, everyone got a CAT scan right there. Oops. Everyone got a CAT scan at 2 months, or actually 6 weeks. So when do we know people responded? When we did the CAT scans. That's why all the diamonds are there. Some people responded later. That's why those diamonds are out there. You can't see them as well. They don't project that well. But a lot of these have arrows. They're still swimming laps, right? They dove into the pool and they're still going. And that means that the drug is still working. The treatment's still working. And the length of this line tells you how long they've been followed. So when the graph was created, some of these people have been followed for 20 months. And there's a little arrow right there. That means they were still responding. Some of these people, unfortunately, have a little line right in here where things started to progress, unfortunately. So the swimmer's plot tells you, for the people who responded, when did they start responding, when did you know about it, and how long did it work? So this is an interesting one. This is called a forest plot. We used to have these a lot, and I'll tell you why. A forest plot tells you, within the group of people who got treated, who did well and who didn't. So if you had this drug that you thought maybe worked in a small group of people, the way to figure that out was to do what's called a forest plot, because it's forest in the trees, I think. I hope I didn't misspeak. There might be a Dr. Forrest somewhere who just kind of went like this. Like I held him up as a, a voodoo doll and stabbed him. Another person thought it was Forrest in the trees. God damn it, I'm Dr. Forrest. I honestly don't know. I'm very sure though that there's no Dr. Spider, Dr. Waterfall, or Dr. Swimmer. What does this mean? So this is a graph from a study looking at treatment of women who have had surgery and chemotherapy for breast cancer with tamoxifen. Who does well, all right? And down the left-hand column are all the different categories. Can we figure out who does well? Is it people who have, first of all, the entire group? DCIS, invasive breast cancer, younger people, older people. By the way, we all know this, right, intrinsically. We never thought about this, but in medicine, you think about this all the time when you give a talk. The definition of elderly changes with time, doesn't it? When I first started specializing in melanoma, I was 35 years old. I was young. Those other people were old. Not anymore. I have a 25-year-old son. The other day he said to me, Dad, you know what? There's this guy I work with. He's way too old to be on the same, the desk with me. I said, how old is he? 32. And my wife and I looked at him like, he said, I know, it's not that old, but relative to everyone else at the desk, he's old. Thank you. Anyway, what does a forest plot mean? The middle line right here means there's no difference in getting this treatment or that treatment. So down here it says tamoxifen or placebo. These are called hazard ratios. It doesn't matter what it means, it just means statistics. A hazard ratio of 1 in general means that it's the same one way or the other. You can see here, for all breast cancer, it doesn't matter that much if you got tamoxifen or not. So the way to figure out who benefited is to start to divide people into groups. Why don't we have these anymore? Because the drugs seem to work regardless of the groups. That's the great news. We don't have to look at these that much because we don't have to start splitting hairs and figure out exactly which subgroup we need to treat because we've gotten lucky. We have medicines that work for lots and lots of people. You can see, so what does that tell you right here? Which ones stand out? DCIS, ductal carcinoma in situ. Way better if you get tamoxifen for up to 10 years if you have DCIS. If you get it for too long, it seems to make it worse. Well, that's an interesting thing right there. Don't give someone with DCIS tamoxifen for more than 10 years. What else stands out? People who are, is that younger? Can't see, younger than 50. It's better to treat them with tamoxifen for longer than shorter. So this is what you use a forest plot for. I don't pretend to be a breast cancer treatment expert whatsoever. I might be misinterpreting the data. But when you look at it, you see that bar down the middle, that's the dividing bar, and then do the trees fall on either side of that fence? Again, hopefully there's no Dr. Forrest. So to summarize, these are the things we look at all the time. When something gets published in the medical literature, they use the same curves over and over and over again. We no longer worry about the percentage of response because sometimes, you'll see in a minute, the tumors don't shrink. It doesn't matter if you, quote, respond. It doesn't matter if we stop it from growing. If you're able to live for 20, 30 years after it stops growing, we'll all take that. So, survival plot. How often do events happen? How long do things last? It's relevant for everything. In the cancer business, it's all about survival, right? It's all about living longer. A waterfall plot. How many people respond to that drug versus how many people the tumor grows on? Very good for highly active drugs, like the BRAF and MEK inhibitors, targeted therapy. A spider plot. Spider plot is what happens over time. It's good for drugs that don't, what we found out, some of these immunotherapy drugs, things grow and then they shrink. So we want to track that with a spider plot. Swimmer's plot, how long does it go on? You know, if you get therapy and it only lasts for 2 or 3 months, that's not as exciting. And then the forest plot, when you're trying to figure out why it works for some people but not other people, you want to divide them into groups and do the statistics for each subgroup. But again, when it works for everybody, not as big a deal. I want to go back a little bit. Everyone always says they're on chemotherapy. And from a technical perspective, it's not quite the same. And so chemotherapy really for us is drugs that kill cancer cells. So if you talk to a chemotherapy nurse or the doctors, they understand that this type of chemotherapy kills cells, the cancer cells, by killing this part of the cancer cell growth cycle, by interfering with the membrane of the cell, by stopping the cell from dividing, by stopping the cell from growing the tubules that it needs to survive in its environment. But it kills cells. When you're in training for cancer, oncology, you learn about, this is called the log-kill hypothesis. And it means that every time you give a dose of true chemotherapy, forget immunotherapy or targeted therapy, every time you give a dose of chemotherapy, you're killing a certain chunk of cancer cells. Unfortunately, and we all kind of know this from our experience and from loved ones and seeing TV shows and documentaries, chemotherapy kills other cells too. Your hair falls out. Your tongue swells, you get stomach disturbances, because it's not specific to just the cancer cells. So what happens, and this is what this graph shows, if you, over time, every time you treat with chemotherapy, you kill a certain percentage of cancer cells. That's where the line goes down. So if you're diagnosed here, you give chemotherapy, you can't give chemotherapy consistently, continuously. So when you're not giving the chemotherapy, the cancer cells are recovering and growing back. That's a cycle. And then you give the chemotherapy again. So what does log-kill hypothesis really translate to the cancer patient? Well, if the chemotherapy works, hopefully you can give enough cycles that all the cancer cells are dead. Sometimes you get surgery to start at a lower level of cancer cells. If the cancer cells don't respond, you end up in the wrong part of the curve. So I'm just saying that because chemotherapy is different than immunotherapy. Chemotherapy works differently. It kills cells somewhat indiscriminately. And again, sometimes, this is how we say it in the biology business, the organism, which means every one of you, can't take enough of the chemotherapy before the cancer cells win. That's the tough part about chemotherapy. So how does immunotherapy work? Many of us who have been in the melanoma area for a long time got into melanoma because, for whatever reason, which we still don't understand, melanoma was the first cancer to really respond well to immunotherapy. There's supposedly this very low incidence of people who miraculously, spontaneously, their melanoma cells are killed by their immune system without any drug. And that was discovered in the 1960s or 70s. That's what drove everyone to look at tumor vaccines, someone asked about before. That's what drove the development of interleukin-2 and interferon, and now the newest drugs. So what have we started to understand that has gotten us to the point where we actually have drugs that are effective, that improve people's lives, that I know that some of you have gotten these drugs and have done very well, and we're glad that you're here to talk to share it with us and to feel good about it. I've been thinking about this. This is the first time we've gotten a group like this of our patients together in a room, except when you're all in the waiting room waiting for me to show up. We probably should do it more often. So, how does this all work? What do we really understand about immunotherapy right now? And I should just emphasize that from a scientific perspective, this is the low-hanging fruit. You know what that means? This was the easiest stuff to discover. Whatever the first stuff you discover that works, it's always the easiest stuff. The harder stuff takes longer. But this is the low-hanging fruit about immunotherapy. So if you look at the top of the page, Here are the cancer cells. And here are the immune cells, the T cells, the lymphocytes that ideally, optimally, in the world, best of all worlds, can kill the cancer cells. By the way, this little box right here, that's called apoptosis. Apoptosis was discovered in the early 1990s. We still don't know how it works. It's some black box, literally. Like, okay, and then the cells undergo apoptosis and they're dead. Everyone goes, we don't know how it works. We really don't. It's amazing to me that a process that clearly must involve a lot of different things that results in the cancer cell dying and going away, we don't understand. Fascinating thing, I was just asked this yesterday by a cancer doctor, or the other day. When you give chemotherapy and you kill cancer cells, some people get a violent reaction to all the dead cancer cells swimming through their system. And they actually have to take special medicines, anti-gout medicines, to prevent that tumor, it's called tumor lysis syndrome. Cancer cells being killed by chemotherapy. They're floating around your bloodstream, all the fragments of them, and it makes you ill. It makes you like you're infected, like you have a fever. Even the people who get immunotherapy or the targeted therapy, who everything melts away on, the waterfall plot where everything goes away, they never get tumor lysis syndrome. Which means that something in this black box is reprocessing these cancer cells in a way that they're not all fragmented, swimming through your body, trying to hurt you. It's really an interesting thing. And I didn't even think about it until a cancer nurse asked me, do you ever have to give these people allopurinol when all the cancer cells die? And I said, no. Very interesting. All right, so ideally we want these T cells to kill these cancer cells. Yay, T cells. How do the T cells figure out what to kill? That's been the great breakthrough. How do you teach the T cells that cancer cells are bad? Because in the past we were worried about how do the cancer cells grow? How do we attack? What's different about a cancer cell than a regular cell? What drug can we give to the patient to kill that cancer cell because it's different in this way? You know what cancer cells are really good at? They're good at hiding from us. They're good at escaping the immune system because every time we're out in the sun, cells get killed or mutated or something like that. And if we didn't have a good immune system, 100% of us, I assure you, would get basal cell cancers before we were 30, especially in New Jersey. 100% of us. So our immune system is working all the time, picking off the stragglers, picking off the cancer cells who aren't good at hiding from us. How do they hide? That once we discovered that, now we have drugs that can address that. So a dendritic cell is typically called a helper cell. The dendritic cell says to the T cell, hey, this is bad. Look at this. It's called a presenting cell, antigen presenting cell. Look at this. This is a bad thing. You want to kill this. And the T cell says, oh, okay. Now I know how to kill things. I just didn't know what to kill. We have two dogs. They're the same. They're on Instagram. They're very popular on Instagram. Don't worry, it'll make sense in a second. One of the dogs, and they're the same breed, but they're different families, and I actually think that one of the dogs, there's some issues with the birth, and I think he's a little not quite right. It's being nice, he's very sweet. The big dog, he's smart, he's, everyone talks about how smart their dogs and their kids are. All right, so the big dog's smart. He figures things out, he figures out how to do the wrong thing, he figures out how to screw stuff up, how to make a mess. The other dog follows my wife around all day long. But every once in a while, the big dog is like, that's a squirrel, that's a chipmunk, that's a whatever. And the little dog literally runs after him, and you can tell she's like, what's the big dog doing? Because I can't think of anything by myself except to follow mom around. That's what we're doing here. The lymphocytes are good at doing things. I'm sure that if a squirrel happened to walk slowly in front of the little dog, he would be able to attack it. He'd figure out eventually that was a squirrel and I should attack a squirrel, it's my breed. But he's got to be pointing in the right direction. That's what we're doing with the immune system. We're pointing it in the right direction. I think that was a stretch. I'm not going to use that analogy. So, this is the low-hanging fruit. Our immune system can recognize this antigen. This little yellow ball right here is the antigen. Our immune system can say, this is a melanoma cell. Take a look at this. Anytime you see this, kill it. It gives it to the immune system through the TCR, which is a T-cell receptor. It doesn't matter. But what if our body what if our immune system recognized all of us, every part of us? Then we get autoimmune disease. And there are autoimmune diseases, like lupus and other autoimmune diseases that can really make people sick. And what happens there is that this system breaks down. Our body starts to recognize ourselves. So what do we do to protect ourselves? We have modulation of this recognition. We have activation signals. It's called B7. B7 helps our immune system recognize the little yellow pill. Or what's that called? Nuprin? Little yellow pill. So the B7 helps us recognize. But even more importantly, the CTLA4 blocks the B7 recognition. So the CTLA4 is basically saying, don't do that. That'll damage the organism. That'll hurt the kidneys, that'll hurt the skin. Don't do that. So what does the cancer cell figure out? Boy, if I can make it so that the T cells are flashing lots of CTLA4, I'll get away with this. I'll escape, I'll hide. So what does Yervoy do? Yervoy blocks that interaction right there. It allows the immune system to recognize the cancer. Now, side effects are because it allows the immune system to recognize us too. Some of you have had this drug, some of you have had those side effects. You know what I'm talking about. You don't have to raise your hand. What about the other side of it? So now we have these T cells that know what to look for. They know what to kill. They know what they should do. And they swim up to the next cancer cell, and the cancer cell's like, yeah, I'm a cancer cell. I'm flashing this little yellow pill. Cancer cells are really bright though. They have this thing called PDL1, and there's another one, PDL2, sticking out. And some of the drawings, they look like those little rock candy sticks, you know? Those little sticks of rock candy. So they're basically waving white flags. Just ignore me. I'm not that bad cancer cell. Swim on to the next guy. Swim on to something normal. I'm normal, because I have a PDL1, PDL2. So the cancer cells have figured out that if they show a PDL1, PDL2, that will shut off the T cell. This is stuff we just discovered within the past 10 years. It's not we. There's a doctor who no doubt will get the Nobel Prize. He's down in Houston. His name is Jim Allison. He started talking about, these are called checkpoints. He started talking about these in the 1990s. He will win a Nobel Prize. The fact that he gets to win a Nobel Prize, if he were here today to speak, he would show up in sandals and a Hawaiian shirt. Because when you're about to win a Nobel Prize, you can dress however the hell you want, right? Very bright guy. So what does Keytruda, what do Keytruda and Devo do? They work over here. They prevent the cancer cell from hiding. These two abilities, these two discoveries, have totally changed the face of cancer treatment, not just for melanoma. I know, for better or for worse, you guys are really focused on melanoma, but those drugs are now approved for lung cancer, kidney cancer, bladder cancer, and as of this past week, Hodgkin's lymphoma. These drugs don't care what kind of cancer it is. They care about how the cancer hides. And all the cancers have figured out that this is the best way to hide. So wave that little white flag. PDL1, I'm fine. I'm normal. You block that interaction, and the T cell can do what it wants to do. If you take cancer cells and put them in a test tube and mix them with cisplatin, chemotherapy, they will die. Okay? That's why chemotherapy works. If you take the same cancer cells and mix them with Keytruda, nothing will happen. The Keytruda requires the T cells to do the dirty work. All Keytruda does is allow the immune system to do what it's supposed to do, what we want it to do. So, old immunotherapy data. This turns out to be high-dose interleukin-2, which was approved in 1998. It started testing in the 1980s. I've done this. IL-2 is, if you enjoy baseball, IL-2 is a 220 hitter who hits 35 home runs a year. Maybe only 20 home runs a year. In other words, someone you keep around because every once in a while the ball goes out of the park, but most of the time nothing happens. So here's IL-2. About 15% of people respond to IL-2. Most of the people do not. All the people get very significant toxicity. It's dosed to toxicity. So 100% toxicity, 15% response rate, and in the end, probability of survival starts at 100%, and by 5-6 years, you're down under 20%. So this is the way things used to be. So I saw a checkpoint inhibitor, and I will give credit where credit is due. This is a slide developed by Jed Wolchuk, who's at Sloan Kettering, who's a great medical oncologist and a real gentleman. And this is how he puts it together for the way our immune system can kill cancer and the way that the checkpoint inhibitors can stop it. So we have, it's all a car analogy, if you hadn't figured that out. We're able to show our immune system what a cancer cell is right here. And if we use the B7-CD20 interaction, it makes it recognition work even better. But the CTLA-4 and in fact the PD-L1, PD-1 slow it down. Those are the brakes. And by giving something like Yervoy, or nowadays Opdivo or Keytruda, or perhaps a vaccine, we can take away the brakes. So what we've done in effect is take the brakes off the immune system. So here's the curve that got Yervoy approved. So everyone knows now this is the survival curve. Percent alive over time. The important thing here, there are two important things here. First of all, this is the old style treatment. Didn't work very well, unfortunately. People passed away from melanoma. This is Yervoy. You know what? In today's world, as you'll see in a second, it's not a great curve. It's not as good as what's available now. But at the time, look at that. People did better. But more importantly, this is called the tail of the curve. If you made it to 2 years out, it's still true. If you make it 2 years out after Yervoy treatment for melanoma and you're still alive, there's over a 95% chance you're going to be alive at 5 or 10 years. That just means that once you've changed the immune system, once you've made the immune system able to figure out that's bad, it keeps working. That's the hallmark of immunotherapy, what makes people excited. So what does that translate into? There's now 2 anti-PD-1s. Remember that PD-1, the little white flag, Keytruda and Opdivo. And there's your waterfall plot. Not everyone responds to Keytruda or Opdivo. This side is Keytruda. Not everybody responds, but most people do. And this is the swimmer's plot. And look over here. These are all the people that responded to Keytruda on that trial. See all those arrows? Everyone was still responding. In other words, once you respond to a drug like this, it seems like you respond for a really, really long time, 18 months. So you have about 40% or so alive in 18 months. It's better than, old chemotherapy, but not great. 18 months here is about the same. The difference here is you get the higher tail of the curve because the interleukin-2 tail of the curve is out here. Now, here's Opdivo. 18 months, survival rate is 75%. We're making a big difference now. That's what's really exciting. And the sad thing is, because ASCO is in 2 weeks, that's the big cancer meeting, and I'm sure there'll be more data on all these drugs presented. I tried to look at the abstract, but the ASCO website is down. Why? Now we're used to this. If this happened 5 years ago, it would be like, oh my God, 75% at 18 months, it's unbelievable. And now they're going to say, well, we changed this. We're able to get up to 80%, at 18 months. Be like, yes, so. All right, next. That's what happens when things succeed, right? You kind of get, oh, all right, blase. Now we have spider plots. Remember spider plots? Some of you, I know, have gotten a combination regimen. The company calls it just regimen. Regimen. They took out the. It's just regimen. And that's a combination of the anti-PD-1, Devo, and the anti-CTLA-4, Yervoy. Helps the immune system recognize and kill the cancer. Make a memory, act on the memory. This is a spider plot of the first the first trial of this combination. What do you notice? Almost everyone who got treated, boom, the cancer cells died. They went away fast, and they went away dramatically. This wasn't like this guy, this person, I don't know any of these people, these aren't my patients. This person, guy or girl, did okay. You know, things shrunk a little bit, but most of the people had a dramatic shrinkage of tumor, and only a minority of people, unfortunately, didn't get any benefit. So that was the initial, that's called a phase 1 study. What about when they did phase 3? And this was just shown last year, and I'll talk about these in a second. The combination of Devo and Yervoy up here, this is something a little different. This is progression-free. You progress if your cancer grows, multiplies, or if you die. So over time, what percentage of people did the cancer progress? This is combination. This is Yervoy alone. That looks familiar, right? That's the same curve we saw there. There's the Yervoy curve. In 2011, that was the paper at ASCO. That was the #1 paper. There's Yervoy now. Doesn't look as good anymore, does it? Because these people are doing way better. This is Devo alone. Keytruda would be in the same ballpark. And this is the combination. What we don't know in the end yet, maybe this year, is if the combination will result in people living longer as opposed to just not progressing. What about some other stuff? You had asked about vaccines. This is the only approved, I guess what I would call melanoma vaccine on the market right now. And it started out as something called T-VEC. Now it's called Imlygic, because pharmaceutical companies spend a lot of money on making cool names for drugs. What is T-VEC? What is Imlygic? Imlygic is a genetically modified herpes virus. You inject the virus into the cancer cells, and here's what happens. You inject it, a virus, any virus, is designed to grow in cells. When we get sick with a virus, what it's really doing is the virus is taking over our body's immune system, our body's cells, and it's multiplying itself. It's replicating itself. It's racing against time. It's racing against the immune system to keep replicating before the immune system figures out how to kill it. Now this is a modified virus, and what it does is it goes into the cancer cells, it makes a lot of itself, it makes a chemical called GM-CSF, the cancer cells die, they release more virus, and then it keeps propagating like that. But it only helps you ultimately, it can kill cancer cells, but it only really helps you if the immune system says, aha, look at those cancer cell fragments floating around. I think I'll kill them. I think I'll try and find other cancer cells like them. So really, the question is, if you inject some of these spots, and this is an actual patient I think treated in Tennessee, if you inject some of these spots, will the other ones all go away? Targeted therapy. I call this the Pacman Curve. I cannot take responsibility for these things, but all of us, I think, are old enough to recognize the Pacman symbol. I don't know why they chose Pacman for this drawing. Dr. Bickenbach before talked about how cancer cells grow and divide, and how the cancer cell life cycle is dependent on certain proteins and things like that. For cancers to become cancers, the cells have to change from normal skin cells to cells that don't want to die, that grow uncontrollably, that don't obey the normal rules. The rules are, if you run out of food, don't grow anymore. If you start to invade other organs, don't grow anymore. If you start to lift off from where you are and spread through the bloodstream and reattach, don't do that, don't grow. One of the main things that helps a cancer cell grow is if a chemical in the pathway that the cell uses to grow and divide and live gets switched on and won't switch off. So the switch goes on and nothing else happens, just keeps growing. And that's what the BRAF, this is called the MAP kinase pathway. I forget what, it's mitogen activated something pathway, phosphorylation pathway. Doesn't matter, just say MAP kinase, M-A-P-K. MAP kinase pathway. If you turn the MAP kinase pathway on, the cells just keep growing. Too much, too fast. The main way they do that, most in melanoma, but in other cancers, about 50% of the time melanoma, is something called V600E. That's the BRAF protein. That's the mutation is called V600E. The protein is called BRAF. There are now 2 drugs that block the BRAF mutation. Not normal BRAF, just the mutated one. Zelboraf and taflunomab. When you block that pathway, the whole way that the cancer grows gets turned off. The cancer can't grow anymore. It's now obeying the rules. It starts to die. Remember that waterfall plot? I'll show it to you again in a minute. Remember that waterfall plot where everything shrunk? There it is. These are 2 different drugs that both block mutated BRAF. Zelboraf and taflunomab. Cool colors, right? What do you see at that waterfall plot? 90% of the tumor shrunk. You know why? That tells you that those cancers were growing almost only because of that one mutation. When you can turn off that mutation, the cancer shrink, then you know that's the only thing causing it. One of the things that happens, however, with these drugs is that the cancer cells are smart. You know, if there's an accident on 287 and we know about it, we don't get on 287 and sit in the parking lot, right? We go around. We figure out, and those roads start to get crowded, but we start to figure out how to go on, I don't know, Ridgedale, Parsippany Road, whatever, those of you who live locally. We get around the blockage. That's what the cancer cells do also. They figure out a way to get around the blockage of both the BRAF and then the next protein in the cycle, which is the MEK. These are from 2011, and this is before any of these drugs were approved. Actually, it's from 2010. It seems so long ago. When it was still, by the way, when a drug has letters and numbers, it's really early in development, because that's what the pharmaceutical company calls it when it's just in a jar in a researcher's lab. So this is PLX4032. These are PET scans. All the dark, forget about the brain, the brain's up there, the body. All those dark speckles are melanoma metastases. And these are people 2 weeks after starting what now is called Zelboraf. See that? That's a liver just filled with melanoma. In 2 weeks, almost all gone. All these spots are in bones in the rib cage. 2 weeks, almost all gone. And then here, this person had stuff everywhere in bones and other spots. And in a couple weeks, almost all gone. That's actually bladder that's supposed to be lit up, and those are kidneys, so that's supposed to be lit up too. But you can see that basically everything melted away. If you have melanoma that's BRAF mutated and you get this drug, you feel better in a hurry. But we run into problems. Like I said, the cancer cells are smarter than we are. And over time, this is progression-free survival over months. This is regular chemotherapy, doesn't work well. But over time, even the BRAF inhibitor stops working because the cancer cell figures out how to get around that blockade. Now, if you combine it, sorry for all the graphs here, but they're all the same, they're all survival curves, you guys know that. So you have overall survival up top and progression-free survival down low. These are 2 different combinations, taflunomab mechanism, Zelboraf Cotellic, BRAF MEK, BRAF MEK. So over here is Zelboraf and Cotellic, and over here is taflunomab mechanism. They look pretty similar, don't they? You have survival benefit, people living longer if they get both drugs than if they get one drug. And over here, you have progression-free survival. That is, things don't grow for a longer period of time if you get both drugs, almost a 5-month difference, and basically the same thing here, especially from the immunotherapy. Basically, if your body can recognize the wrong thing, if it can recognize part of your body, it can cause all sorts of side effects. Most common thing is a rash, but it can also affect your endocrine glands, your liver, your lungs, your stomach, and cause neurologic problems, arthritis, all sorts of bad things. And I know that many of you in the room have experienced them. But I also know that because you're in this room, many of you, despite those side effects, have had significant benefit as well. This is a curve that just kind of gives you an idea of the fact that we always think about taking a drug and getting the side effects pretty quickly. But it turns out with the immune drugs, it takes a while. So this is in weeks. And the first thing that happens typically is a rash, and that's in about 3 weeks. This was Uruguay data. And then you get the diarrhea and colitis about 2 months out. And then the other things seem to occur, the endocrine stuff and the liver stuff seem to occur even further out. This is on average. So what's had to happen is essentially a retraining of all the cancer doctors out there. What are these side effects? How do you manage them, and when do they occur? Because they're chemotherapy, you get chemotherapy and a week later your hair starts to fall out, and that's just, everyone's used to that. This is different. This is harder. Don't worry, I'm getting close to the end. How do you pick a treatment? I think nowadays most people, first of all, want to know the mutation status. Do you have that BRAF mutation? Because you can't get the BRAF and MEK inhibitors unless you have it. Something doctors call performance status. We don't want to, when you're doing risk versus benefit, if you're already not a very healthy person, we're very apprehensive about giving you something that could have higher incidence of side effects because you're not in a position to take it. So we're going to err on the side of, if we can, less side effects, unless the melanoma is being very aggressive, clearly growing fast, causing a lot of symptoms, causing pain, causing other issues, breathing issues, any other issues. Where it is, it's in the bones, it's in other things that we're more worried about, it's in the liver. These are things that would tilt us towards picking a treatment that we might be worried has more risk, but also potentially more benefit. But they end up being something even harder to predict. And those of you who I've treated know that we go through this stuff. And aren't we lucky to have this discussion, right? What are your expectations? How do you approach this? In the United States, cancer's a battle, right? There isn't a single famous person that dies of cancer where the obituary doesn't say they lost their battle. It's all militaristic terms, which is fine, but everyone has a different attitude about that. And we're all fighters on some level, but everyone has different expectations. So part of our job is trying to figure out what's important to you guys. Because some people, we've had discussions where we go through the things and like, you know, we really think you should do this because it's growing fast, da da da, and the family's like, yeah. And the person, you know, sitting in that on the chair says, you know, I don't want the side effects. I'm not going to do it. The family's like, I don't want to do it. And so that it's always up to you. And ultimately, and I think I told all you this, the right decision always comes from your heart. And there's always other things you can do. But again, to emphasize how lucky we are to be able to have this discussion now. So what's next? ASCO's in 2 weeks. ASCO's always covered by all the major networks. The New York Times will be there, the Wall Street Journal. They have to have press conferences after every major paper so that the press can ask the doctors what's going on. There's a great website, which is actually based in the Princeton area, called OncLive, onclive.com. And they'll be there and they'll be interviewing doctors continuously. But what people are really looking at now is combining these different drugs to get the synergistic benefit, perhaps. It's always more complicated than that because sometimes this drug makes that drug's side effects worse. New injectable treatments, sort of vaccines, although they really haven't worked perfectly. And then altering the therapy based on specific tests or biomarkers. When Dr. Bickenbach showed you that curve of the people who got sentinel node biopsy, and he said, you know, overall it didn't help people. It only helped the people who had sentinel node positive. So then the question is, one of the questions should be, are we doing sentinel node biopsy on too many people? Why can't we figure out better who we should do sentinel node biopsy on? Or moreover, why can't we in some way figure out which people have a positive sentinel node but will never ever go on to develop any more melanoma anywhere else in the body? Why can't we do that? And that's really about personalized medicine, figuring out which test is better. So there actually is a genetic test, and some of you may have had this. It's the first of, I'm sure, many to come, and it's called DecisionDx Melanoma. And this was the first publication of DecisionDx Melanoma. And what it does is it takes your initial melanoma biopsy, and it runs a genetic test. It tests 31 genes, but only 28 of them are real. The other 3 are control genes to make sure that they ran the test correctly, quality. 31 genes, and they look at the expression of those 31 genes. Are they there? Are they overexpressed? Are they underexpressed? Are they mutated? And then based on those 31 genes, they come up with a score. And of course, that's their intellectual property. I don't know how they get the score, but I know that it's a lot of genes. And actually, I don't think the BRAF gene is in there. As it turns out, it's not even in there, but I'm not sure. And based on that, you get a report. Are you class 1 or are you class 2? So look at the difference there. This is, again, a survival curve, but it's survival without metastatic disease. Look at this. If you're class 1, which means you're low risk, their initial study, they could, with 100% accuracy, pick people that regardless of anything else, regardless of Breslow thickness, ulceration, mitotic rate, anything else, 100% of them were alive without metastatic disease. But if you're class 2, again, regardless of anything else, doesn't matter how thick it was or if you're ulcerated or mitotic rate, only 38% of people were alive without metastatic disease. This is the sort of test that in the future will dictate how we do those clinical trials. Because this test can tell us who's actually at risk. Who should we even be thinking about giving these medicines to or giving more surgery to versus, hey, you're fine. Go see your dermatologist. You don't have to wait in the waiting room anymore. Honest to God, if people say this anymore, all the time, don't take it personally, and we don't want to come back here anymore. Sounds good, Debbie. Here's another possible thing. I talked about the PD-L1 white flag. If you're PD-L1 positive, this is the combination immunotherapy. So Yervoy plus Opdivo, Opdivo alone, or Yervoy alone. 3-way trial. The top curve, I showed you this one before, that's combination, that's Opdivo alone, and that's Yervoy alone. But over here, these are the people who the tumor was expressing a lot of PD-L1. So the tumor was waving a lot of the white flags. And look what happens. You don't need to take both drugs if your tumor is PD-L1 positive because the Opdivo alone curve is identical to the Opdivo plus Yervoy curve. Now this is early. This is the early data. We don't know if this is going to hold true when they do the final analysis. So what does that mean? First of all, it might mean that PD-L1 doesn't need the Yervoy. That's pretty obvious, right? It also might mean, potentially, that the only thing Yervoy does is increase PD-L1 expression, which makes the Opdivo work better. And the final thing it might mean is if we can figure out a drug to increase PD-L1 expression, you might only need Opdivo. You might never need to risk the side effects of the combination. And it might be simple, like, I'm making it up. Maybe tetracycline increases your PD-L1 expression. Maybe Zyrtec increases your PD-L1 expression. We have no idea. But that's how I look at that curve. Very interesting. We don't know yet, and we're not really testing for it. So there's a lot of other combinations, and you should look for those combinations to be at ASCO and in the newspaper reports. I don't think any of them are really prime time. They're all under investigation right now, where you're getting Opdivo or Keytruda or something like that in combination with a newer drug. These are some of the companies that are trying to develop things. The hottest topic right now is something called CAR T-cell, CAR T-cells. It stands for a bunch of long medical words. What it basically means is technology to prime your lymphocytes to recognize the cancer even better. Not just in melanoma, but other things. When should we be giving treatment? Should we be giving it when we first get biopsied? Should we be giving you 1 dose of Devo just so for the road, right? To make your immune system recognize things so it never comes back? We don't know. Pause. It's a very exciting time. I'm so happy that you're all here this morning and able to share this stuff with me. I hope that I was able to show you a little bit about how we analyze things. I know it's a lot of information, but I'd be happy to answer any questions. We're going to have a break after this, and we're going to come back with Donna Reagan, who's going to talk about sunbeds and her personal quest. And also we'll have a patient panel to talk about their experiences and answer questions. So thank you very much.